Welcome to Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective.
Welcome to Behavioral Health Today, a Triad production. I'm your host, Dr. Graham Taylor. My guest today is Dr. Jorge Petit. George is the Strategy and Development Advisor at Zero Overdose, a national nonprofit organization dedicated to preventing overdose deaths. With over 30 years of experience in community and public psychiatry, George has been a leading advocate for vulnerable populations, particularly those affected by substance use disorders. His extensive career includes founding Quality Healthcare Solutions and serving in leadership roles at Coordinated Behavioral Care and Beacon Health Options. We're excited to have George with us today to discuss key overdose risk factors, harm reduction strategies, and how Zero Overdose plans to expand and influence future overdose prevention policies. George, welcome back to our show.
That's great to be here. Thanks.
Nice to have you. Hey, just remind us again, we've had some chance to work before, but what brought you into this field, this prevention field, and into your role as advisor at Zero Overdose?
Yeah, so it is really part of who I am in terms of, having been and being a public sector psychiatrist. Believer in really trying to figure out how do we, impact some of these public health crises that we're dealing with, especially the opioid crisis. So this kind of felt like it was exactly, the right organization at the right time to be able to really help think about amplifying the message and raising awareness around the importance of overdose, prevention and risk screening and safety planning. But there's also, a personal stake in this. I'm a parent of two young men who are out and about in the world, and I worry, every day about their coming across inadvertently, contaminated pills, substances, whatever it may be, and they're having the knowledge base and the ability to be able to understand what to do or how to do it differently. And that's what we're trying to do at Zero Overdose, is really raise awareness around how do we identify someone who might be having difficulties or challenges? How do we create a safe setting where we can have a conversation about what some of the risk factors are for unintentional overdose events, and then creating a safety plan so that we can prevent folks from dying. And the reality is, for every overdose death, there are 10 overdose events that get reversed. And we really have to be able to intervene in those moments, folks that are potentially, at risk to, prevent more folks from dying.
That's really kind of a summary of your mission statement as I've read about it and learned about it more. Is this dedication to reducing these overdose events by expanding access to overdose safety planning and education of individuals and those communities, individuals that are going to be at risk.
Yeah, no, absolutely. And I think that what we're seeing is, luckily nationwide, we're seeing a little bit of a downward trend in terms of overdose deaths, and that's fantastic. But I also worry that because we're seeing a downward trend that, attention might be no longer paid as much to, the opioid crisis as it has been before. And I worry about that. I worry that we're going to take our eye off the ball. But I also think that, we've emphasized so much, naloxone, which is a great and important intervention from a harm reduction perspective. And we should be, continuing to promote that as much as possible. But the reality is, if you're needing naloxone or you're using naloxone, it's because you had an overdose event. We want to get as upstream as possible and not necessarily needing to use naloxone, but really being primary prevention focused around how do we work with individuals upstream that are actively using to really mitigate some of those risks and prevent them from ultimately having to use naloxone. So that's sort of the framework that we're using.
Yeah. I love that idea of being upstream and really focusing on the primary, not the secondary or tertiary prevention, but the primary piece. How do we get in early? Speaking of that just for a second, and I want to come back to that piece and what you guys are doing around entering more and more, getting people, connected with at the primary upstream position. But there are a number of pathways that can lead to, accidental overdose. You guys clearly cite these, including active substance use, critical stressors in one's life, and maybe even an early recovery. Suicidal ideation comes into play, overdose incidents themselves, even transitions like from incarceration to higher levels of care, et cetera. All of these are easy pathways, not easy, but accessible pathways into accidental overdoses. And you just mentioned a stat there, and I know I was reading on your site that early data from 2022 indicates that there are nearly 110,000 overdose deaths occurring. It's the highest number recorded ever in a single year, you were saying. But you just mentioned also too that maybe some of this is starting to come down a wee bit. We're in 2024 now. Talk about that piece and that shift.
Yeah, I think what we've seen in the last year is about an average of 10% decrease in the number of overdose deaths, which is, again,
That's significant.
amazing. We're incredibly happy about that. A lot of that, I think, has to do with sort of the promotion of naloxone distribution and saturation, at the federal level, at the state level, at the local level. All those things are great, but we're still seeing, the rates of overdose that still exceed, anything that we had seen prior to COVID. So, we have a lot more work that we need to do. The other part of this is, which I think is the most, challenging aspect, is that for every overdose event, about 65% of those individuals that do overdose, there had been at least one potential opportunity for intervention. And I'm thinking about it from the perspective of human beings, 6 out of 10, we could have actually maybe done something had we been able to figure out what was going on and how we could intervene to help that individual not ultimately die from an overdose. So I think there's a lot more work we have to do to, raise awareness and really destigmatize this idea around substance use, especially opiate use disorders.
Maybe in some ways that ties in earlier around this idea that there are pathways, and you're talking about trying to get upstream, something in primary prevention, and talk about maybe where are some entry points early on where there is unique and particular vulnerability to this that we can plan in an active way to get in early, set some things up that can really be beneficial to really reduce that overdose risk.
Yeah, I think it starts with like just a universal screening. I think everyone that sees a primary care doc or any physician should ask a couple of questions about their, prior substance use history, and sometimes you do get a little bit of that information being gathered, but not systematically. And you're certainly not asking about, potential prior overdose events. But, even if someone is being, screened, there are some other high risk conditions or situations. Like, for example, someone who's prescribed, an opioid, the doctor should be able to have a conversation with them and helping them understand that there is, potential risk. Not everyone, but certain people actually, are at higher risk for becoming, addicted to the opioids and then ultimately maybe potentially having an overdose event. So it's like thinking about, ways that you can intervene. So in primary care, I think in some, OBGYN, settings where especially women might be thinking about some of those risk factors. I think, across the board in schools, like you're doing regular, you have to, like, when you're going to school, you need to like verify that you've gotten all your vaccines. This should be part of that, like, right. Not just what's going on with the individual student, but ultimately with the family as well, and figuring out sort of those contexts. So schools, healthcare settings, but also just, I think, raising awareness in the community that we're seeing. I mean, there's a couple of recent articles about, librarians having to deal with and face with significant numbers of these public health issues in libraries, places where people congregate. So in laundromats and libraries and other places where, potentially folks might, be at risk, is critical for us to just, explain what these issues are and offer a simple tool and a solution to have that connection, have that level of engagement with an individual, and hopefully get them on a path towards getting more care, but hopefully preventing them from overdosing.
Really good. You mentioned some things that are kind of external things, community organizations, doctors' offices, schools, et cetera. You also mentioned at the beginning that you've got 2 sons. How have you brought this into the family, and how maybe can parents think about maybe replicating something that you've done?
Yeah, so I've written a little bit about this and sort of in my blog. I think as a parent, it's our responsibility to be able to, disseminate information. I think there's been a lot of concerns about the information that's out there and making sure that it's, valid and reliable. We have dinner every night, or we used to have dinner every, now that they're adolescents and dating, and they're not as around as much as they used to be. But, when they were smaller, we would have conversations and be very, very open and frank about, all these issues, including, substance use, and not being, Pollyannish, thinking that, they weren't ultimately going to either be exposed or even think about, experimenting. So, being very open and transparent about it, but also just training them. Like, I actually sent my son to college with naloxone kits. He's been trained. He understands what the signs are. Hopefully he'll never have to use it, but God forbid there's ever a situation, in his dorm where someone, is unconscious and might have overdosed. Like, he knows what to do.
Really
You
cool.
need to do that across the board. Like, everyone should be doing that. Like I would make them have an naloxone kit in their backpacks, and they were like, "Dad, like, why are you doing this to us?" Because I'm like, in the same way that if you have a food allergy, you're going to walk around with an EpiPen, which my son
You bet.
has a food allergy, and he has an EpiPen. I'm like, this is the same thing. Walk around with this, because God forbid you should ever be confronted with a situation where you might be able to intervene. That's why that statistic of 65%. Like, I want to make sure that any bystander,
You bet.
is equipped to be able to help an individual.
Really good. In that training around those things with either you're working with healthcare, professionals or families like you're doing with your own or community members to both identify some of the risk factors and implement these safety plans. Your model also incorporates not just overdose prevention, but it's centered around an overdose risk questionnaire and a safety plan template. Help our audience understand a little bit more about that.
Yeah. So the way that we structured it, the questionnaire really is about identifying the risk factors, right? What are some of the things that, make you more at risk? And, some of the more obvious things are injecting drugs, using alone. And once you identify some of these risk factors, it's really being able to have that conversation about what or how the individual can understand those as being risk factors and what they can do to be able to, to decrease some of those. So that's like step one, is really identifying the risk.
Give us just a few more of the risk factors. You're talking about, are you injecting? Are you using alone? Pop out a couple more for us, would you?
Yeah. So it's using, greater amounts, thinking about
Mhm.
it, develop some tolerance, like someone that's coming out of a hospital, or they, they've been incarcerated for 30 days as
Yeah.
they're coming out. Obviously,
Yeah.
their physical tolerance to the drug that before they were using whatever, let's say 2 or 3 bags, that, with a different set of different variable of tolerance, will actually could precipitate an overdose. So it's
Thanks.
really thinking about these different aspects of, the route. Use it, like I said, IV is very different than smoking it, very different than snorting it. Using it alone. I think there's some things about like using it alone. If you don't have an naloxone kit readily available, maybe you should. Who in your circle is the one that's going to kind of keep an eye out for you?
Yeah.
Or if you've got a buddy that you're doing, like maybe you should alternate who's using when, so that someone's, around and awake and conscious, so that you don't both overdose. So like there's practical things, but it's these conversations that I
Yeah.
think are so critical and so hard to have, because I think, traditionally we come from this very abstinence focused perspective where, having a conversation about maybe decreasing the amount of drug, or maybe saying, well, don't use IV, but use smoke it, is like, oh my God, as a clinician, how am I having these conversations when I feel like I might be condoning drug use? But the reality is, from a harm reduction perspective, what we're doing is really mitigating the risk so that they don't die. And I think that message is critical, right? This is not about, condoning continued active substance use. It's about helping an individual, decrease their risk and ultimately work with them to get them, into
Yeah.
more long-term care. So it's very much based on harm reduction, which is,
Yeah.
no wrong door, no wrong path. It's all
Mhm.
about the individual and where they
Mhm.
want to go to and be at. And it's about respecting that. And as challenging as that is for a clinician, I think it's important, because that's how we see, folks ultimately get connected to care, is when we're
Right.
able to have these conversations. And the safety plan is iterative. This is something that changes, it'll change constantly. So we want to be able to have these conversations ongoing with folks.
We'll be right back after word from our sponsor.
Continuing education is both a requirement and a learning opportunity, but finding the right CE provider can be challenging. AATBS, a triad company, offers continuing education for psychologists, social workers, marriage and family therapists, counselors, and behavior analysts. CE courses are available both individually and as part of our new All Access Pass. All Access Pass provides a library of over 250 unique courses. That's more than 800 hours of CEs, with new courses being added every month. As a special offer, Behavioral Health Today listeners can save 15% on CE purchases. Visit us at aatbs.com/BHT and enter promo code BHT15 during checkout. That's aatbs.com/BHT. Check out our library and check off your CE requirements today.
Yeah, that's really good. In some ways, we could say it's maybe equivalent to if you're going to have, sex at a young age, and that's going to be the risk factor of pregnancy. Well, what can you do to prevent, that happening? So it's going to happen. People say, well, don't do it, or don't use drugs. Well, if they are, then there's a whole different conversation and a whole different world that we need to step into
Right.
to prevent some very consequential and life altering behaviors or consequences that are going to occur. Why not just say, hey, this is going on. What do we get to do?
Right. Absolutely. Being realistic about the reality of the individual, right? As much as I would like everyone to not be actively using drugs, that's not my prerogative, and I have to work with individuals on helping them get to their path of recovery. And I think that's the critical thing.
Yeah. What do you see in terms of zero overdose effects? I know, or impact. I know you guys operate nationally and you work with major organizations like NACOM and SAMHSA, and you're collaborating at the state and national stakeholder level, which is really cool. But what are you seeing some of the benefits of your work, of your questionnaire, the safety plans, really getting people to embrace this? What are the outcomes that you're seeing?
Right. So I think, the thing that I think is most impactful about our training is really being able to provide the necessary construct and language around how do you engage an individual who's actively using drugs and what can you do to solicit the information necessary to be able to create a safety plan. I think, like I was saying before, I think clinicians, or healthcare workers have a hard time having those conversations. And what we see with some of the community members is similar in terms of really being able to have an open dialogue that's judgment-free, that's stigma-free, that's really about where the individual's at and helping them get to the next level. So I think what we've seen is sort of this like, oh, thank you, because I wasn't able to think about how I can have this conversation with this individual, or the language that I could use to be able to help them identify their risks and create a safety plan. So it's really about providing them those mental scripts that'll help them. I also think, a lot of our frontline workers, all the issues about workforce challenges I think are huge, but, our frontline workers that are dealing with individuals, who are actively using drugs need a lot of support and a lot of training. And so I think this moral injury around working with these individuals who are, repeatedly overdosing and what that does to them. So it's really about being able to create an environment where we have, safe conversations and some containment around some of the anguish that people feel around these really challenging statistics and numbers, because when you think about it, it's like 100,000 deaths. It's such a large number. You can't even begin to fathom what that means. But if you can bring it down to like, a particular case or a particular individual, I think it resonates deeply because, in this sector, who hasn't, come across or encountered an individual who has overdosed. So it's really about making this much more relatable, much more humanizing in terms of the work that we're trying to do.
Yeah, you're talking about trying to work upstream as much as you can in primary prevention. And in terms of working with this model that's getting in early and educating people and giving them kits and doing the questionnaires, is there an upstream? Is there even further upstream that you see some opportunities for?
So, yeah, I think at the city, state, and federal level, I do think that there needs to be much more of an emphasis on, primary prevention. I think, again, like I said, we've been focused very much, which I think is great, like on harm reduction and naloxone and fentanyl, strips and stuff like that, which all those things are incredibly important, or even, promoting the use of medication-assisted therapies. All those interventions are really critical, but it would be nice if we're able to, early on, starting, middle school, high school, really be able to get the word out there, really be able to think about how do we work with doctors around better management of, the prescription of opioids, especially around pain management, where you're either prescribing opioids too freely or you're not doing it enough. And we see that a lot with minoritized groups in terms of not getting appropriate, assessments and management of their chronic pain conditions. So it's trying to be as upstream as possible in terms of thinking about, the raising awareness and amplifying the importance of, some of these strategies. But I would like to see, in the same way that we have a suicide prevention federal framework, I'd like to see something similar around overdose, like an overdose prevention framework across the country that really speaks to what are some of these areas that we have some levers of control that we can pull to prevent people from overdosing.
Given the stigma that's just so almost inherently a part of this work, and what are some of the greatest challenges and roadblocks or barriers do you find in trying to expand these things that make so much sense to me? What are some of the challenges?
Well, I think we still view individuals who use drugs from a more, if there's, I think, stigma and judgment around individuals who use drugs, right? We think it's a moral failing still. We think that, they should just stop it. Like, what are they doing? Like, why are they doing this to themselves? So I think it's really about, again, humanizing the experience and being able to understand that this is a medical condition that is chronic and relapsing. So it's really putting it in the framework of a medical model. I was recently talking to Dr. Stephen Lloyd. He's this renowned physician, and he's actually, for those that actually saw Dope Sick, the model of the character, Michael Keaton's character, the doctor, was actually based on his life. He's, very open about his own recovery journey. And what he says is that, if it wasn't for people like him that are actually, out there and showing that they also, as a physician, struggled with issues of addiction, we don't have role models. We don't have images of individuals that have actually, successfully recovered. And what he says to me, what he says is, addiction is treatable. Treatment works and people recover. And I think we have to continue to say that, there are effective treatments out there, and we constantly are, knee-jerk responses. Abstinence is the only way to do this. And for some it may be, and for others it's not. And there are effective treatment options, there are effective medications. And we have to continue to reframe this as not a moral failing of an individual, but as a chronic relapsing medical condition that requires, all of our care and intervention like we would any other chronic medical condition.
I like that piece right there, because you're talking about, as challenging as this is, there are steps that can be taken to prevent overdose deaths for those that are still choosing to use. It's going to be, this is my choice. And we would think, well, maybe, the whole idea of meeting people where they're at, we want to say somebody has diabetes, well, just change your diet, or maybe there's other things, but we want to go to those things that are going to eliminate it. But maybe someone has a challenge around smoking. Maybe someone's going through a divorce. Maybe someone's having a hard time where food is a comfort or stress reducing, way to get through different challenging times. And so we really miss an opportunity to join somebody where they're at. And as cliche as that sounds, it's essential. So if someone's still using, we would say, well, we got to get them to stop using. No, not necessarily. Not right now. Maybe we meet them where they're at and we make it safe enough. And then maybe from there, we move to a different place.
Right. And I think that, what we see a lot, and it's trying to sort of, combat some of these very sort of siloed approaches to how individuals are assessed and treated is, I was recently in a training and someone said, well, we had, assessed this individual who we thought needed inpatient detox, and he just wanted, medications for his opioid use disorder. And they were like, no, we're recommending, we're the doctors, we know what you need. You need to go into inpatient. And the guy was saying, I don't want that. I just want meds. And they discharged him from their clinic. And I was like, that's not harm reduction, right? That's not the way to engage someone, right? Because if what they want is medication in that moment, give them the medication, work with them, and then figure out, even though they might still be actively using, figure out how do you ultimately get him to understand that maybe inpatient is the way to go, but it might not happen on your time frame. And I think we have to change the way that we think about engaging with folks around this very, very challenging, condition.
Yeah, I think I could see that as a struggle of, no, the answer is only going to be the cessation of use. Just stop. And not right now. Maybe we see that in the long term, and maybe we can get into the long term,
right,
if we can do the immediate in the right way.
Right. Absolutely.
And if we don't, maybe we even set somebody up, to overdose because we're maybe naively, or not even naively, or maybe naively, but maybe kind of ignorantly, or maybe just kind of stubbornly saying, no, this is the only way to do it. And we set them up for failure, maybe like you're saying here, a risk of harm and maybe even death.
Right. I think we're still very structured in the way that, the regulatory framework sort of drives some of our care. So we know if your assessment says you got to do this, like anything beyond that seems like it's just people are inflexible or nimble or nuanced in the way that, they're approaching the individuals. And I think that, we're seeing, I think, a little bit more of this, shared decision making, much more, patient advocacy around their own treatment. So I think we have to get to that point, when we're looking at substance use disorders, managing opioid use disorder in a very different way.
This may not be a fair question, but the things we're talking about right now, and we're talking about maybe misunderstandings and how to intervene. If there would be one key misunderstanding that someone has about addiction, what would you say it is?
It is a chronic medical condition that individuals struggle with, and there's relapses, and the path to recovery is not linear, right? It's going to be very individually determined. And some of the stuff that you mentioned before, like, these social drivers, unemployment or poverty or food insecurity or, unstable housing, all these things are part and parcel of an individual's path to recovery. And if those things aren't balanced or aren't, well well managed, it's really hard to think about, leaving something that causes you pleasure, even though it's causing you a lot of damage,
Yeah.
if everything around you is so bleak. So I think we have to be thinking about this more broadly than just, even like with diabetes and changing diet or
Hmm.
smoking cessation.
Exactly.
These are multifactorial conditions,
Yes.
require a much broader approach than just, I'm going to give you, an insulin, for your diabetes and, tell you to stop eating, sugar.
Yeah.
It's much more complex than that.
Yeah. And I think it's a hugely missed opportunity for folks to be understood, to be joined when we don't look at it this way. And what I'm appreciating that you're doing is you're kind of teaching us how to think best about this, how to approach this, not, our linear model, our regulatory model. We can have and we can hold on to that as long as we want, but we're going to have overdose deaths because of it if we adhere to something that is limiting and rigidly and maybe even egotistically professionally. It says, I know the only way to get rid, to be healthy is to stop using. Well, maybe not today.
Right.
So appreciate the nudging around. We've got to think about this differently.
Right.
We've got to come at it with this different perspective and to trust a process that can have some really good steps, even if it doesn't seem sensical, to continue to use while we have a pack of, naloxone strapped to this guy's belt. But in time, if we can join this person, maybe some things can change in their lives that could be really beneficial.
Absolutely. I think it's about being person-centered. It's about having a
Yeah,
conversation
exactly.
that takes into
Exactly.
account what the individuals need.
That's the person in this that gets lost sometimes, isn't it? I don't mean
Yeah,
to interrupt, but
absolutely.
yeah, I think it's the person-centered piece, which takes us back to the relationship.
Right.
Trusting if we can form that people are using for a reason.
Right.
And usually more times than not, it's going to be some rupture or some difficulty in a relationship in their lives and feeling so very alone and the pain being too great. And we get to come in and if nothing else, begin to form a relationship to keep them safe as a start.
Absolutely. Yeah, no, I think that's critical. I think we've lost that, in a lot of our interactions in medicine or in healthcare writ large, right? Where it's become a much more transactional approach to,
Yeah.
the issues. And I think if we could take a step back and realize we got, a human being in front of us who's got, a myriad of issues that they're dealing with, that we may or may not be aware, but it's that curiosity. It's about really figuring out what's going on and how can I, in my position as, let's say, as a physician, what can I do to be able to help you? And I don't have all the answers, and nor should I have the answers, but I can work with an individual on figuring out what are some of the next steps. And again, if it happens today, great. If it happens next week or next month, like it's got to be a process. Like no one, that's why, everyone like, come January 1st, everyone signs up for the gym and then, 10 days later, they stop going to the gym. It's like, it takes a while to be able to really create behavior change in a meaningful and sustained way.
And with that perspective, we get to say change is a process and all these things are a process. But for now, let me help keep you alive.
Right.
Yeah.
Yeah, absolutely.
Let me keep you alive.
Yeah.
Well, hey, George, we're kind of rounding the corner here in our time together. But if there's a takeaway message you'd like to leave for our listeners today, give us one, would you?
Yeah, I'm going to just repeat, what Dr. Lloyd has said is that, addiction is treatable, treatment works, and people recover. People actually recover. So I think it's important to keep that in mind, that there are, a ton of effective interventions out there and that we as individuals really can make an impact on someone, in preventing them from overdosing if we have the right tools in our hands in terms of understanding what some of the risk factors are and really being able to promote, safety planning a little bit more broadly than where it's currently at. So, again, I think it's having a sense of hope that recovery is possible is, I think, really a critical mantra of ours.
I love that. Well, hey, as our listeners maybe might want to follow up with you later on after this show, where can they learn more about Zero Overdose, maybe access some of your trainings and your resources, and get involved with this whole mission of something that can be very life-changing for folks?
Yeah, so you can go onto our website, www.zerooverdose.org. And we have tons of information and resources. And yeah, I think, the more we can expand and amplify our message around the importance of this, the better. And in all different settings, not just healthcare. So yeah, we're open and interested in doing this. We can do this in English. We can do it in Spanish. Yeah. So in whatever way we can come and assist, it's definitely part of our mission.
That's good, man. Well, George, you're a good man, brother. You got a great message. I love your passion and love the enthusiasm. Thanks so much for your message today and for being with us on the show. It's been great to have you.
Yeah. Thank you.
Also want to thank you, our listeners, for dropping by and joining George and me today. It's always great to have you with us. And hey, by the way, we'd love to have you help us out by spreading the word about our podcast to help us grow and reach more people, allowing them to discover the valuable insights that get shared in this show. To help us out in this way, would you please leave us a review and share this podcast with a friend? And just a reminder, our episode today and its resources, along with all of our other episodes, can be found on our webpage at triadhq.com/PhD. Thanks again for being with us on the show, and we'll look forward to having you back with us next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Triad Behavioral Health Network, all rights reserved.